Hello everyone, I'm Vinoli. Welcome back. Today in this video we are going to discussing about CVP line insertion. So before we start, I would like to tell you that overview of the topic. Introduction, types of central line, indications and contraindications of central line, technique, basic principles, specific sites, basic material, CVP line insertion and complications. Introduction. Central venous access refers to line placement into the large vein of the neck, chest or groin, and it is frequently performed invasive procedures which carries a significant risk of morbidity and even mortality. So these procedures should be carried out in operating theatre or high dependency care areas and always using a fully aseptic technique. Next we will see different types of central line lumen. One is single lumen, double lumen and triple lumen. Now let's see what are the indications for inserting a central venous catheter. One is volume resuscitation, emergency venous access, nutritional support, ino drops, hemodialysis, central venous pressure monitoring. Volume resuscitation. In order to rapidly deliver large amount of fluid or blood. For example, a person short central venous catheter is indicated. Emergency venous access is, for example, withdrawal or for medication administration. Third one is the nutritional support. In order to deliver nutrition directly into the blood, when foods or liquids cannot be given through the mouth or stomach or intestine. For example, total parenteral administration. Next one is ino drops. Critically ill patients need supports of ino drops which cannot be given through peripheral line, and hence such cases central venous catheter is indicated. Hemodialysis. To connect a person with renal failure to a hemodialysis machine that clears a body of waste and extra fluids. And other indication is central venous pressure monitoring. Next we'll see contraindications of CVP line insertion. One is coagulopathy, patient non-compliance, thrombocytopenia, skin infection over the site of access, obscure anatomical landmarks, and those who have hemo or pneumothorax on the contralateral side. Let's say common sites for inserting central venous catheter. One is internal jugular vein, right and left, subclavian vein, right and left, axillary vein, right and left, groin for femoral vein, and PICC, peripheral inserted central catheter. Next we'll see how to approach internal jugular vein. First we have to maintain the patient positioning. Mostly right side preferred, and maintain the Tendenbach position and head turned slightly away from the side of the vein puncture. Needle placements in the central approach. First have to do the triangle formed by the clavicle and the sternal and clavicular heads of the sternocleidomastoid muscles is located. Then have to use 3 fingers of the left hand or gently placed on carotid artery. Then gently needle should be placed at 30 to 40 degrees to the skin and lateral to the carotid artery. So the aims of the procedure towards the legislator limping under the medial border of the lateral head of the sternocleidomastoid muscles. The vein should be 1 to 1.75 cm deep, or deep romping in the neck should be avoided. Next we'll see positioning of the subclavian approach. So here we have to maintain Tendenbach position. So most preferably right side of the patient, like supine position, head neutral and abducted and shoulder neutral with mild retraction. So this strengthened back positions we have to maintain 10 to 15 degrees of the angle. Needle placement of the subclavian approach. So here 8 to 10 centimeter level the needle should be placed, and the junction of the middle and medial thirds of the clavicle, and at the small tubercle in the medial deltropectoral groove. A needle should be parallel to the skin, and also it can be kept for longer period like 6 months or 3 months for the chemotherapy, and aims towards the subclavicular notch and just under the clavicle. Next, we are moving to the femoral approach. So here we have to maintain the supine position of the patient, and the needle placement, the medial to femoral artery we have to select, and needle held at 45 degree of the angle, and skin insertion 2 cm below the inguinal ligaments, and which is the aims towards the umbilicus. Next, we are moving to the equipments. What are the equipments required during the CVP line insertion? So first, ultrasound and sterile ultrasound sheath, sterile tray and sterile dressing, and then sterile field gloves, gown and mask, and shielding central line kit, saline flush and chlorhexidine. Like cleaning fluid 2% and chlorhexidine, gluconate in 70% isopropyl alcohol is recommended for the CVP line insertion in the procedures. And then Legnogyne for 4 ml, 2 vials of 2% is maybe the reasonable thing. And sutures and scalpel and pressure bag to attach to the monitoring, and needle or the cannula over the needle, and central venous catheter, guide wire, dilator, and oncotic clips, syringes, blue and green needles, and 3-way taps on for the each lumen. What is pre-procedure evaluation? Prior to the line placement, the patient will meet with the physician and supporting staff to explain the procedures and evaluate any special conditions that may affect tube placement. It is important that you tell them if you have any had the previous central lines, if you in the neck or arm, previous any line infections, radiation and skin infections and bleeding problems, or any allergies like antibiotics, dye, lidocaine. So these all the histories we have to priorly inform to the physician. Now we will move on to the general procedure description. So first we have to wash our hands, so which is involved in the sterile technique, and non-sterile gowns and gloves. And next, clean the areas and apply the sterile field. Make sure to have some spare gauzes, swabs and to be ready. And the central venous line insertion can be performed by an interventional radiologist or any general surgeon. This interventional radiologist, using the X-rays and ultrasound guidance along with minimally invasive technique to perform the procedure, and apply the sterile sheath to the ultrasound probe, which is using the defining of the anatomy under the ultrasound guidance, inserting the lidocaine continuously and subcutaneously and around the internal jugular. Use scalpel to make a small incision in the skin, which is approximately 3 mm. This should be done cutting away from the wire so as not to damage it. The cannula with the stillet is inserted at the tip of the triangle formed by a two head of the sternocleidoid muscles and clavicle. This direction of the needle is slightly lateral. Once internal jugular is punctured, the stillet is removed and guide wire is passed and catheter is inserted. Post catheter placement, we have to use the lidocaine, has time to work flush all the lumens of the line, and then clamp off all the lumens except in the shouldering port. And under the ultrasound guidance, to take the shouldering needles attached to the syringe and inserted into the internal jugular vein. So after that, aspirate the blood from each port and flush with the saline or sterile water. When the blood is freely aspirated, remove the syringes and immediately insert shouldering wire. So should be pass easily. After that, cover with sterile dressing with using the decaturn and suture the line to allow the 4 points of the fixation and dressing with a clear dressing. So that the incision point can be clearly seen. And after that, we have to obtain the chest X-ray for internal jugular and subclavian lines. These procedures itself last approximately 30 minutes to 1 hour. Usually, the patient does not require overnight of the hospitalization. The patient and their family will be instructed on care of the catheter and discharged after the sedative medications results. Coming to the risk. So there are few risks associated with these procedures. The main potential complications are infection, bleeding, air embolism, dislodgement of the line, injury to an adjacent organ. So these are the common complications after the CVP line insertion. So you should report the complication if they are not controlled by a medications provider, and then dislodgement of the catheter should be reported very immediately. Now we will see the maintenance of the CVP line. So here 8 hoursly we have to flush the capsules, and then central short channel is used for measuring the central venous pressure, and the rest 2 channels are used for medications and TPN, and then the dressing should be changed at regular interval, and catheters should not be kept for more than the 3 weeks. So the final most coming to the nurse's role. First, we have to monitoring the signs of the complication and assess for patency of the CVP line. Sterile dressing should be done to prevent the infection, the CVP care per the hospital protocol. The length of the line, interfering catheters should be recorded and regularly monitoring.
That's today. Hope you liked this video. Thanks for watching.